So friends, we will continue our topic on drugs which are used in chronic gout. We have already discussed the uricosuric drugs. Now we are discussing the uric acid synthesis inhibitors. The drugs in this group includes the allopurinol and febuxostat. First, we will be talking about the allopurinol. So before discussing the allopurinol, first we should know how does the uric acid form inside the body. So let's discuss the uric acid formation. So what happens? Normally, whenever the cell is broken down, there is a release of lot of purines, like there is release of hypoxanthines and xanthines. These are basically the purines, and these purines are basically responsible for formation of uric acid. This hypoxanthine, when released by the cells, it is acted by the enzyme known as xanthine oxidase. This xanthine oxidase converts this hypoxanthine to xanthine, and when xanthine is formed, it is again acted by the enzyme xanthine oxidase, and it converts the xanthine to uric acid. In this way, uric acid is formed. So what we do, we will give the drugs which have similarity with the hypoxanthines, like allopurinol. We give allopurinol to the patient. Now what does happen? This allopurinol goes and bind with this enzyme known as xanthine oxidase and inhibit this enzyme. And this enzyme, when it is inhibited, it is unable to convert the hypoxanthine to xanthine, and then again to xanthine to uric acid. So uric acid in this way is not formed with the use of allopurinol. But before, I would like to tell here, whenever we give allopurinol to the patient, it is again acted by the enzyme known as xanthine oxidase to convert this allopurinol, which is a half-life of 2 hours, to a more longer acting form known as the alloxanthine to alloxanthine. It is converted to alloxanthine when it is introduced inside the body, and it has a half-life of 24 hours. So alloxanthine is formed, and in this way allopurinol acts to convert or inhibit the xanthine oxidase and preventing the uric acid formation. About the pharmacokinetics of allopurinol, it is about 80% absorbed orally, and after absorption it goes to the circulation, but it does not bound to any plasma protein. It has no plasma protein binding. So that's why it is excreted unexchanged about 1/3, and rest of the form is excreted as alloxanthine in the urine. About the interaction with the use of allopurinol, it has an interaction with 6-mercaptopurine and azathioprine. Whenever we give allopurinol to this patient, they prevent the degradation of 6-mercaptopurine and azathioprine, as a result of which their level can increase in the blood. So we have to reduce their dose to prevent the toxicity of 6-mercaptopurine and azathioprine whenever we are giving allopurinol. Also, when allopurinol is added with probenecid shortens the life of alloxanthine. In return, allopurinol prolongs the half-life of probenecid whenever they are combined together. Also, there are certain drugs whose metabolism being inhibited by the allopurinol. These drugs include your warfarin and theophylline. Because they are not metabolized whenever their allopurinol is combined with them, so their toxicity can occur. The warfarin and theophylline toxicity can occur, so we have to be careful whenever we are combining it with allopurinol. Also, if the patient is already taking allopurinol, on the top of that, if we give patient the ampicillin group of drugs, then the incidence of rash increases with this combination. About the adverse drug reaction with allopurinol, although these adverse reactions are uncommon, but the most frequently noted is the hypersensitivity reaction, where the patient can have rash, fever, malaise, and muscle pains. And this incidence further increases if the patient is having renal insufficiency. Stevens-Johnson is a serious but rare side effects noted with the allopurinol, so you should keep this in mind, that Stevens-Johnson syndrome can occur with the use of allopurinol. Gastric irritation in the form of headache, nausea, dizziness are noted, but they are very infrequent. So that doesn't warrant to withdraw the drug allopurinol if these side effects are noted. Liver damage can occur, but it is very rare. About the precautions and contraindications, so whenever we are giving the allopurinol to the patient, we always advise to take plenty of fluid. So there is liberal fluid intake is advised with allopurinol. The use is contraindicated in pregnancy and lactation, and also we should be very cautiously using this drug in an elderly, in patients, in children, in patients with liver and kidney damage. We use it very cautiously. About the uses of allopurinol, it is the first choice drug in chronic gout. It is prescribed for both overproducers and under excretors of uric acid. It is prescribed in severe cases and in those cases where there is a lot of tophi formation and in patients with nephropathy. The long-term use with allopurinol reduces the incidence of tophi and nephropathy and even reverses the nephropathy. They are also prophylactically used in secondary hyperuricemia. Secondary hyperuricemia is seen with the cancer chemotherapy, with radiation exposure, and in those with thiazide diuretics. They are taking thiazide diuretics. The prophylactic use, we have to give prophylactically as allopurinol to the patients. Also, as we know, they prevent the degradation of 6-mercaptopurine and azathioprine. So whenever we try to potentiate their action, we have to increase their action of these drugs. For example, in cancer chemotherapy, and whenever we want the immunosuppression action of these drugs, we always prescribe with allopurinol so that their level remain more in the blood and the desired action is achieved. About the dosage, it is termed as 100 mg once daily dose, and it is gradually increased after a week to 300 mg once daily dose, and the maximum dose we can give is 600 mg per day. It comes in the tablet form as tablet zyloric as 100 mg and 300 mg tablet. About the cautions with allopurinol and other uricosuric drugs, they are not started in the acute attack of gout because it can even worsen the acute attack of gout. What does these drugs do? Whenever these drugs are given, they fluctuate the level of uric acid. That leads to the solubilization of the uric acid and again recrystallization of the uric acid crystals and can precipitate the acute attack of gout. So we have to be very careful to not give them in acute attack of gout. Whenever we are giving them, we have to give cover with non-steroidal anti-inflammatory drug and colchicine for the initial 1 to 2 months so that the acute attack does not precipitate with these drugs. It was also used for leishmania, Kala-Azar, but because of the poor efficacy, this drug is abundant nowadays for this action. Now, another uric acid synthesis inhibitor drug is the febuxostat. It is basically the non-purine xanthine oxidase inhibitor, and it has action almost similar to allopurinol. Either it is equally or more effective than allopurinol in reducing the incidence of gout, in reducing the uric acid level. It is very rapidly orally absorbed, and it has a very high plasma protein binding, and whenever it goes to the liver, it is oxidized and undergo glucuronide conjugation and later excreted by the kidney. And this febuxostat has a half-life of 6 hours. About the adverse drug reaction with the febuxostat, the most common being the liver damage, and you have to monitor liver function tests with the use of febuxostat. Other side effects are diarrhea, nausea, and headache. They are known to interact with drugs like 6-mercaptopurine, azathioprine, and theophylline. So, while prescribing these febuxostat with these patients, we have to be careful. About the uses of febuxostat, they are generally used as an alternative to the allopurinol whenever we are not able to give allopurinol due to contraindication with allopurinol, or the patient who are intolerant to the allopurinol, or the patient is having hypersensitivity with allopurinol. Only then we give the febuxostat to the patient. Also, febuxostat is not indicated for malignancy associated hyperuricemia. Similarly, as with allopurinol, we also require here the cover of 1 to 2 months with non-steroidal anti-inflammatory drug and colchicine to prevent the acute precipitation of the gout. The dosage of febuxostat is 40 to 80 mg per day. Another new drug is the recombinant xanthine oxidase enzyme. It is the rasburicase. What this rasburicase do? It will oxidize this uric acid to a more soluble form, that is the allantoin, and then excreted in the urine. So uric acid level reduces with this drug rasburicase.